Hi, Isabella.
Hi, good morning.
Good morning.
Thank you for being here today.
Of
I
course.
appreciate it.
Thanks for inviting me.
Diabetes is one of those things that everyone, like we think we know, but then there's so many new things every year coming up
Yes.
that I think it's good to
Yeah.
keep up to date. So,
When I share the screen, sometimes my presentation mode and the slide show mode kind of gets flipped. So just let me know. I'll have to, because I have two screens in front of me, so that you don't have to see my presenter mode.
do you want to start sharing it
I can start sharing. Yeah, sure.
so that you can leave it
Yeah, that sounds fine.
the mode?
Okay. So, let's see. What can you see? Can you see my just the non-presenter mode, right?
Yeah, now I can see all the slides on the side. And
Yeah, okay. So let's see. What do you see now?
okay, so now I think this is the presenter mode.
Yeah, okay. How about now?
Okay, now I see just the
Yeah,
one.
okay. That's, yeah. Yeah, I've done this enough number of times. I know that it gets messed up. There was one talk I just gave and I didn't realize, they never told me. And it was in presenter mode and all my notes were showing. It was not that I have that many notes, but it's still kind of.
No, but still. And notes can oftentimes be helpful, even if it's just remind yourself.
Yeah.
Right, like with topics. I like notes. So yeah, so today, so this week is spring break for
That's
Seattle
right. For
schools.
Seattle, yeah. Our spring break was, I live on the east side. It was last week, so we're all done.
Okay. Yeah, so I know that there's a few people that might not be here today because of that. But I think we still have plenty of people coming in.
Is that who I think it is? I think I see Abby. You're not allowed.
Yes, hi.
You already know everything. Hi, Abby. Good
Hi.
to see you.
You too.
And everyone else, if you want to leave your cameras on, as always, I know sometimes you can't, but if you can and you want to, please turn them on so that, we can, it's oftentimes nice for the speaker to have faces to speak to instead of black boxes. So. And I see it's 8:01. I think we can get started. So welcome everyone. Thank you for being here today. Welcome to our geriatric grand rounds. Today we have Dr. Subramanian from the Department of Medicine. She's an associate professor in the Department of Medicine from the Division of Endocrinology. And she's here today to speak to us about diabetes in older adults. And the reason I asked her to come was because I heard so many great things about her and about her thoughtful insights when taking care of our Med D patients, and then also when taking care of her outpatients. So I figured we're lucky to have her here. And she has different interests in obesity and diabetes and insulin resistance and cholesterol. So again, right, what we wanted to do, but she also has clinical interests in general endocrinology, according to her page, and we didn't get to talk too much about it, but I think it's a lot of what helps us, right? So thank you so much for being here today.
Thank you, Isabella, for inviting me and for that very sweet introduction. I do wear many hats, but diabetes and lipids are my big ones. I also have a big primary care diabetes hat that I wear, helping as a liaison between our Diabetes Institute and primary care. So the topic I'm going to talk about is something I'm quite involved in and passionate about. And so hopefully you'll find this useful. With that, I'm going to minimize the boxes so I don't get distracted. So, and I think I'll talk for probably about 45, 50 minutes, and I'm happy to take questions So the way I've outlined this talk today is to look at the scope of the issue of diabetes in the older adult population and the unique challenges that older adults with diabetes present. And then how do we use the newer therapies for diabetes, particularly specifically type 2 diabetes in our older population, and how to incorporate use of diabetes technology briefly in our older adults. So with that, I'm going to present two patients. They're both my patients. This picture is not of Cher, but just a representative. But Cher is a very lovely 73-year-old woman who's had 10 years of type 2 diabetes. She has stage 3 CKD, depression, hypertension, among a bunch of other things health-wise. She's a retired nurse. She moved from the Midwest where she was a psychiatry nurse. And she moved because they wanted to be closer to her daughter who lives in the area. She lives with her husband, Mike, in the basement of their daughter's home. And recently she was diagnosed with Alzheimer's dementia. She gets her care in the Harborview Memory Care Clinic. From what I understand, it's moderate stage, but she's quite functional. She has her diabetes regimen is shown there. She takes metformin, 500 milligrams twice daily, so half dose. She's on glargine for basal insulin, and she takes fixed dose prandial insulin using Lispro. And she forgets, so her husband cues her to take insulin, and her A1Cs range between 7.9 and 8.4, and her eGFR is anywhere between 42 and 46. So is there something we need to do for her? Is this okay? We need to consider, do we need to modernize her regimen? So these are some things to think about in her. And then we have Don, our second patient. He's 83. He's a retired geologist and an avid hiker. He's had diabetes, type 2 diabetes for 15 years. He has microalbuminuria. He had a myocardial infarction about 5 years ago, and he had 2 stents placed, and his ejection fraction is 40%. And he takes metformin for his diabetes, and he's also on other medications. You can see there, his blood pressure is 132/76. His eGFR is 55, and he has albuminuria. And his A1C is pretty similar to Cher, who we saw in the last slide, hovering between 7.9 and 8.4. Do we need to do anything for this gentleman? So let's look at the scope of diabetes in older adults. And for purposes of today's lecture, and as a non-geriatrician, I'm going to use the term older adult for ages 65 and older. And I understand there are different groups that consider over 60 or over 70 as an older adult, but we'll use over 65 today. The prevalence of diabetes is increasing, especially in older adults. Over 25% of adults over 65 have diabetes. And globally, the numbers are staggering. Over 130 million, approximately 135 million is what I saw. And this figure is expected to double by 2045. So almost 300 million adults over the age of 65 will have diabetes. And the duration of diabetes, as shown in that figure there, is also pretty high. So the older you get, the longer you've had diabetes. So individuals over 80 have had diabetes for over 10 years, as seen in that green bar in the rightmost corner there. Also, diabetes is the 7th leading cause of death, and most deaths are from cardiovascular disease. Over 75 individuals with diabetes have really significantly elevated rates of complications. So that's both microvascular as well as macrovascular. Death from hyperglycemic crisis and frequent emergency room visits for hypoglycemia. But this is all probably familiar to you based on the kind of persons you see in your clinic. And not surprisingly, the average annual cost of medical expenditures for adults over 65 with diabetes is double that of a younger adult cohort. It is also, I don't need to tell this group that all older adults are not the same. But it is important to recognize that older adults with diabetes, who span multiple decades, 4 decades of life, anywhere from above 60 to 90 or older, is really not a homogeneous group. And it includes robust adults who are still working, employed, such as the 2 women in the bottom of the screen. The woman who's stretching, she's actually 90. She trained to become a fitness trainer at 80. I forget her name. And then on the right is Iris Apfel, who's 99, very successful businesswoman, especially in the last decade or so. And then there's also the individuals who are frail and nursing home residents. So functionality is is a spectrum. Cognitive aspects as well as physical status also vary widely. The psychosocial environment is the individual community dwelling versus nursing home or assisted living. And for purposes of today, we're going to talk primarily about community dwelling adults. I'm not going to go into nursing home care of diabetes. As age advances, a complexity of diabetes care also increases, and research findings oftentimes have to be extrapolated from clinical studies done in adults under the age of 65. Resource availability in this older adult population is variable, and clinical presentation, importantly, can also be variable. In fact, there are leaner adults who may have type 2 diabetes because with aging, there is aging of the pancreas and beta cell loss. So there's that aspect as well as muscle loss, which can lead to insulin resistance. Additionally, it's important to realize that type 1 diabetes, an autoimmune condition, can also develop at any decade in life and can happen in 60, 70, 80, and 90-year-olds. So something to keep in mind. Modern management of diabetes requires that one needs to tailor the treatment recommendations to the individual. So are there guidelines for management in our older adults? So in 2012, the American Diabetes Association actually put out a consensus statement. And since then, every year, the ADA releases standards of care, SOC, which is updated and is a living document. And there is a chapter in there for older adults. In the 2021 SOC, it's chapter 12, which actually highlights all the important aspects of management of older adults. There's the International Diabetes Federation Global Guidelines, which is now 8 years old. The American College of Physicians addressed care of older adults in their statement for management of diabetes. And the Endocrine Society in 2019 also has a clinical practice statement or guidelines, rather, for treatment of older adults. So for this talk, I'm going to be mostly highlighting the ADA, but much of the information I'm presenting here comes from the ADA and the Endocrine Society, and I would recommend you looking through those because they're quite well done. But the general principle or themes in all of this is the need for individuality of treatment plans based on functionality, presence of comorbidities, overall health, and personal values. And outpatient regimens should be tailored to avoid hypoglycemia. And don't forget to incorporate lifestyle changes. Metformin can be used as an initial agent in older individuals. So how can we make decisions in our patients with diabetes? In 2018, the ADA and the European Society of Diabetes released a consensus statement where they came up with this decision cycle where the patient is at the center and the goals of care are to optimize quality of life and prevent complications. So this is very appropriate for our older adult population also. And starting at the top right, the primary goal is to assess the key characteristics of the patient, consider factors that impact treatment choice, make a shared decision with the patient or the caregiver if there might be one, something that all groups can agree on, and implement it and appropriately monitor on an ongoing basis. And this is highly relevant, especially for our older adults, although it is important for all patients with diabetes. But there are certain aspects in older adults with diabetes that we should consider. One is the presence of age-related conditions, which I'm sure all of you are familiar with, cognitive dysfunction, functional disabilities, vision and hearing, highly relevant to patients with diabetes, because if you can't see, if you're on injectables, it's really hard to administer it yourself. Falls, again, increased risk of fall with especially some of the newer drugs because of side effects, which I will talk about as we go along. Fracture risk can be increased with certain medications. Polypharmacy, of course, is always a problem. Urinary incontinence, again, I've highlighted here because certain medications should not be used in this setting. And depression can result in non-adherence to the medication plan and suboptimal management. On top of age-related conditions, there's also aging, age-related changes in the heart and the kidneys. In the heart, arterial stiffening and thickening leads to can lead to issues. Progression of atherosclerosis is also quite common, and renal aspects include changes in the microscopic changes in the kidney, including decrease in the number of glomeruli, glomerulosclerosis, atrophy, and then this can lead to functional and clinical changes, such as a drop in GFR, and clinical changes such as progression to new CKD. So these are all things you want to keep in mind, and these are all highly relevant to some of the newer agents that we're going to talk about. Again, risk of hypoglycemia is already a limiting factor for people, especially with long-standing type 1 diabetes. And this is not just in older adults. All adults are prone to hypoglycemia, but it's amplified in older individuals due to the poor adaptive physiologic response to lower glucose levels. And this can lead to poor outcomes. Older adults have unrecognized hypoglycemia. Hypoglycemia can trigger vascular events, worsen cognitive decline, which can lead to falls, fear of falls, confusion. Everything can be amplified, and it's exacerbated by frailty. Meal skipping, poor appetite, all these repeated insulin dose skipping, these are all issues, or duplication of dosing can lead to hypoglycemia. So these are all aspects that we want to keep in mind. And in these individuals, use of something called a continuous glucose monitor may help. And this will be the last part of my talk. So knowing all this about our older adults, what is the best approach to pharmacotherapy in 2021? So let's look at the options that we have for managing type 2 diabetes. There are currently 12 classes of drugs approved for diabetes. And for many years, we had insulin, we had sulfonylureas and metformin, and then the insulin analogs came up, and until 2009, so this was on the left side, this little ladder shows you all the different medications, so therapeutic agents that we had. But from 2009 to 2020, you can see there's a whole bunch of newer agents that have entered the foray. And oftentimes what we get asked is there's so many different medications. How do we keep track of all of this? So why did this? You've also probably know that there's been this exodus of so many clinical trials and on different medications in the world of diabetes, and we're going to talk about all that today. But there's a reason for that. So until 2008, there was really not much of a guidance for diabetes drug development. Diabetes was classified as a non-infectious chronic disease, and really there weren't any specific guidelines or rules for a specific drug in diabetes. And there weren't any cardiovascular outcomes trials that were conducted in our older agents like metformin and sulfonylureas, and a drug could get approved with as little as 250 patient years of exposure. And all diabetes medications were approved because they lower blood glucose. No real specifics needed to be done. You didn't need to look at cardiovascular outcomes. But that all changed in 2007 because this meta-analysis that was published by Steve Nissen on the effect of rosiglitazone and the risk of myocardial infarction. And what the authors concluded was rosiglitazone was associated with a significant increase in the risk of myocardial infarction, which was about 34%, and with increased risk of death from cardiovascular causes that had borderline significance. So this and a few other studies pretty much rang the death knell for rosiglitazone. And I should say here that a subsequent study was actually specifically designed to test cardiovascular safety of rosiglitazone and did not confirm these findings. And also, I want to point out this meta-analysis was, by the time this was published, rosiglitazone, which was marketed then as Avandia, had been out in the market for about 10 years. Now, even though the safety of rosiglitazone did not, cardiovascular safety study did not show the increased cardiovascular risk that this meta-analysis showed, its use of rosiglitazone has been negligible. But nevertheless, that was the study which triggered the FDA to put out guidance for industry in diabetes. So in 2008, the US FDA issued guidance to the pharmaceutical industry, setting new expectations for the development of anti-diabetes drugs for type 2 diabetes. This expanded the scope and cost of research necessary for approval of these drugs. So international agencies now require that all hyperglycemic anti-hyperglycemic agents demonstrate glucose lowering as well as exclude clinically meaningful increases in major adverse cardiovascular events. So the trials should be designed appropriately. The new drugs need to show that they lower glucose. They don't have to show cardiovascular benefit, but they shouldn't show any increase in cardiovascular complications over time. And so these were all so it was a big document that was put out, and so the trials have to be conducted with these certain specifications. And there needed to be about 15,000 patient year exposure. So since then, after the guidance, FDA guidance, there have many CVOTs have been completed for many, pretty much all of the newer drugs. Most have involved use of drugs of 3 classes, and those are the DPP-4 inhibitors, dipeptyl peptidase inhibitors, the gliptins, so sitagliptin, alogliptin, linagliptin, et cetera, and then the GLP-1 analogs, which I'll talk about, and the SGLT2 inhibitors. I will not be talking about the DPP-4 inhibitors. Suffice it to say that they've shown safety and non-inferiority compared to placebo. There have been no safety signals, but there has been no benefit from the gliptins. So my talk will highlight the SGLT2 inhibitors and the GLP-1 receptor analogs. There have been about, by my count, 19 CVOTs conducted since 2008. And a lot of good information has come out from these studies, and that's what we'll highlight in the next several slides. So let's talk about the SGLT2 inhibitors. So what are these drugs? So SGLT2, sodium glucose cotransporter, is a transporter that's present in the first part of the proximal convoluted tubule. So normally, about 180 grams of glucose is filtered through the glomerulus, but in people without diabetes or with well-managed diabetes, there is zero glucose in the urine. And the reason for this is that the SGLT2, this cotransporter, sodium glucose cotransporter 2, reabsorbs 90% of glucose in the first part, and anything that escapes it, is reabsorbed by SGLT1 in the distal part of the proximal convoluted tubule. So this results in the zero glucose or no glucosuria. So when you block SGLT2, there is inhibition of glucose absorption in the proximal nephron. And this results in an increased urinary glucose excretion of about 60 to 80 grams per day. So this is self-limiting, so meaning you don't keep losing glucose, and the loss of glucose results in weight loss, and the weight loss is also self-limited. So a person doesn't continue to lose weight. There is a plateauing of the effect. There's the effect of these drugs is not dependent on insulin secretion, which is an exciting aspect of the mechanism of action of these drugs. And these drugs have been around since the 1800s, late 1800s, when fluorescein, which is found in the bark of the wood apple tree, is actually the basis of these drugs because fluorescein causes glucosuria, and that's where these drugs were invented from. The available drugs, these are the gliflozins or the flozins. There are 4 drugs available: empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. The commercial names for all of these are Jardiance, Invokana, Farxiga, and Steglatro. A lot of folks know these drugs by the trade names, which is why I mention it. So all 4 drugs that are available on the market have had CVOTs. There's been about, I think, 34,000 patients, if I don't think I did the math right, but 50% of patients in all these trials were above the age of 65. So in the next several slides, we're going to go over what the studies have shown. So I've compiled it, and I'm going to show you data on meta-analysis of all these studies. So the striking effects of SGLT2 inhibitors have been from a cardiovascular standpoint. 3-point MACE, which is death from cardiovascular causes, non-fatal MI, and non-fatal stroke, is the common endpoint in all these CVOTs. And that's a theme in pretty much all the CVOTs for all the drugs. For the SGLT2 inhibitors, you can see here there's a relative risk reduction of 10%. And this is, there's some heterogeneity in the studies. Declare TIMI, which is dapagliflozin study, and Virtus CV, which is ertugliflozin, didn't actually show the 3-point MACE. The primary endpoint was not met. And similarly for cardiovascular death, there is some heterogeneity, but overall it's a 15% risk reduction. But that is not the case for heart failure hospitalization. So there is a very strong effect on heart failure with these drugs, and this is a class effect. There is a benefit, as you can see, favors treatment on the left of one here for all the agents that are available on the market. So the meta-analysis showed a very strong effect. The hazard ratio is about 0.68. So that's a 32% risk reduction. So in 2019, the DAPA heart failure study was then published, which actually highlighted the benefits of dapagliflozin in heart failure. So this study was a landmark trial where they looked at patients with and without diabetes, and they have and dapagliflozin was shown to be superior to placebo in preventing cardiovascular deaths and heart failure events total. The benefits were in patients with both diabetes as well as no diabetes, and the primary composite endpoint in these individuals was cardiovascular death and heart failure outcomes. Average age of inclusion in the study was 66. There were patients who were above 75 also. These were patients with heart failure with reduced ejection fraction. And when DAPA was added to standard heart failure therapy, there was a reduction in heart failure risk. And the drug was pretty well tolerated when added to standard heart failure protocol medication. So this resulted the FDA to add a heart failure indication for this drug. Specifically, this, as I mentioned earlier, this is likely a heart failure, is a class effect, but DAPA is the only drug which for now is indicated or has an FDA labeling for heart failure benefit. So this has been since November 2019. So this heart failure benefit of SGLT2 inhibitors is really not a fluke because the Emperor Reduce study was published last year, which is using empagliflozin versus placebo. And again, a very similar population of patients with heart failure with reduced ejection fraction. Average age is about 65 to 67 years. And 50% of patients had diabetes, and there was a significant reduction in cardiovascular and in the primary outcome, about a relative risk reduction of 25%. And this was driven, as you can see in the bottom here, you can see the curves. You don't even need to see the numbers, the curves separate. And this is the heart failure hospitalization curves. And there's a striking decrease on the empagliflozin. Similarly, these drugs also have a significant effect on kidney outcomes, and CKD progression, and again, this is another class effect, is reduced by 38%. So with all these drugs, so there's heart failure benefit as well as a CKD progression benefit. And this was highlighted again by the Credence trial, where they took patients with type 2 diabetes and looked at the primary outcome of end-stage kidney disease or doubling of serum creatinine, renal or cardiovascular death. And this was the drug that they used was canagliflozin, and the eGFR for enrollment was anywhere between 30 and 90. And again, you can see the curves here. They separate. The blue line is for the SGLT2 inhibitor canagliflozin. And this trial was stopped early due to the significant benefit. So essentially, the Credence trial showed that the SGLT2 inhibitor canagliflozin is superior to placebo in improving glycemic control and reducing adverse renal events in patients with diabetes and established CKD. The DAPA-CKD study using dapagliflozin was also published last year and showed similar results, so suggesting that there's a striking benefit in renal disease progression also. And looking at all the patients who are over the age of 65 compared to those adults under 65, there was a meta-analysis that was just recently published. And the benefit holds for SGLT2 inhibitors in older adults or adults over the age of 65 also. So the striking benefit you can see here, this is cardiovascular death or heart failure, both. So this is the primary endpoint, heart failure, hospitalization, and renal endpoint shown in the bottom here, favors SGLT2 inhibitors very strongly. So you're probably wondering, okay, that's all great. So how is this happening? So none of the studies were actually designed to examine mechanisms responsible for this cardiovascular, how this happens. But there's many theories that have been put forth, hemodynamic factors. There's a reduction in blood pressure that you get from the SGLT2 inhibitors, maybe decreased preload, decrease in aortic stiffness have all been postulated. There is natriuresis, so that could reduce blood pressure. However, there's a considerable interest in the ketone hypothesis, by which when there's a switch from glucose to fat oxidation in the liver, there's an increase in plasma ketones, and ketones are preferentially taken up by the myocardium, and maybe there's the benefit is something, has something to do with this. We still don't know, so stay tuned. It's certainly not glycemia because the A1C reduction by these drugs is pretty modest. It's in the studies, it's about minus 0.25%. In clinical practice, by my observation, it's maybe half a percentage point A1C reduction. So yeah, it's definitely not due to the glucose lowering benefit. Similarly, on the kidney, there's something called tubuloglomerular feedback. SGLT2 inhibitors may restore the tubuloglomerular feedback, and this reduces hypoxia. So kind of these drugs have been postulated or proposed as the beta blockers of the kidney. Again, maybe some channel changes in the tubules. It's really, again, this is not something we understand fully. So
this is, if I could interrupt for just one second, this is Steve Plymate.
Yes.
And the reason I'm asking the question is that we're embarking on a clinical study, a clinical trial, a phase 1/2 clinical trial with a fatty acid synthase inhibitor, which is going to affect fatty acid oxidation. This is for cancer. Okay. But that's going to affect the ketones.
Yes.
So is the ketone increase thought to be the primary benefit? Is there good evidence for that?
No, there's no, we just don't. It is purely a hypothesis. The shifting, we really don't know. Okay. So I don't know that in your study with the fatty acid synthesis did you say inhibition maybe? I don't think
it inhibits FASN. Yeah. So far, they've been used for NASH and have worked well.
But, no, this is all active areas of research. Much of these are being studied in animal models, but we still don't know. It's
okay.
a very hot area of research is all I can say. I don't know that we have answers yet. Okay, so that's about the SGLT2 inhibitors. So I'm going to move on to the GLP-1 analogs. So these have been around much longer than the SGLT2 inhibitors. These first came in the market in the mid-2000s. These are agents which work on they're analogs of GLP-1. GLP-1 is a hormone that is an incretin. And for that, you need to know understand how incretins work. So there's a difference in the amount of insulin that's released by the pancreas after an oral versus an IV glucose load. That is called the incretin effect. So it's the term that is used to describe greater insulin secretory responses after an oral glucose load than after an IV glucose infusion. So you can see here in healthy patients in the top panel here that after the oral load, there's such a robust insulin secretion from the pancreas. That doesn't happen after you give it IV. In diabetes, in type 2 diabetes, that peak or the spike in insulin secretion from the pancreas doesn't happen. So you could consider type 2 diabetes a reduced incretin effect or an incretin deficiency. And so using this principle is how GLP-1 receptor analogs were created. And these drugs, what they do is they bind to the endogenous GLP-1 receptor, and GLP-1 has many different effects. In the GI tract, it can slow down the stomach and the brain. It suppresses food intake by suppressing the appetite center. There's some anti-inflammatory effects. In the pancreas, it results in increased insulin secretion. In the heart, there are some beneficial effects and cardiovascular protective effects that these drugs cause. Again, this is another area that is actively studied, and we might know a little bit more about the GLP-1 analogs and their mechanisms than the SGLT2 inhibitors. So clinically, GLP-1 receptor agonists come in two flavors. They are short-acting, the two drugs on top, that's exenatide and lixisenatide. And there's the long-acting drugs, which can be given either daily or once a week. So there's liraglutide, dulaglutide, semaglutide, and the drug names are all given in the bottom there. These are pretty good A1C reducing drugs, anywhere from 1 to 1.5% A1C reduction. And they are also good weight loss drugs. And they vary in the amount of weight loss. These are numbers in kilograms. So a good 5-pound weight loss or more. So they do have weight loss used for weight loss also. There's minimal risk of hypoglycemia. They can be used in renal insufficiency. And some have cardiovascular benefit, not all. So that's shown here. There's some heterogeneity in effect. So what does the data on GLP-1 receptor analog show? So again, putting together all the different studies, there's 6 or 7 of them that are available. And there is a decrease, 12% relative risk reduction in 3-point major adverse cardiovascular events. In cardiovascular death, about 12%. It's again, there's maybe a trend here based on some studies have shown better benefits than others. The exenatide and the lixisenatide studies were not positive studies. So that's probably what's causing these results. Also, I want to mention that there's not much, there's a mild heart failure benefit effect, but not significant. So looking at the other interesting thing about these drugs is that there might be a significant benefit in older individuals than in the adults under 65. This is from the same meta-analysis I showed you for SGLT2 inhibitors, but there is a benefit in older individuals also. So how did these drugs decrease cardiovascular risk? In cardiovascular outcomes trials, these drugs cause the A1C reduction, weight loss, decrease in blood pressure. There's a slight increase in heart rate, which is thought to be due to stimulation of the AV node. We don't understand it, but that can happen. And the pattern is different from that of SGLT2 inhibitors, and the mechanisms are not quite clear. They're antioxidant pathways, anti-inflammatory pathways have all been involved. And as I mentioned, there is heterogeneity with agents and a lack of a class effect. And liraglutide and semaglutide, so that's Victoza and Ozempic. I'm getting a feedback, so
There's also, while we talk, there's also a question in the chat.
Oh, okay. I can't see the chat.
Yeah, so I will let you know. It says here that okay. Is there an age effect in the risk reduction due to CV death, particularly with SGLT2 inhibitors? That is, as individuals get older above the age of 65, the benefit decreases. Alternatively, did the study investigating rosiglitazone and myocardial infarction look at the age as contributing factor? Also, does the duration of disease affect the outcome and benefits? Is it common for 65 plus individuals to develop type 2 diabetes, as was the case for your Mayo case study?
Okay, maybe you can break down the questions.
Sure. The first part was, is there an age effect in the risk reduction due to CV death with the SGLT?
The SGLT2 inhibitor, is there an age effect in cardiovascular death? So cardiovascular death is not the primary benefit from the SGLT2 inhibitors. It's mostly heart failure hospitalization. So I don't know if, I don't think there is, no.
And I think the question was, as individuals get older, would the benefit decrease? Even
so it does the benefit of SGLT2 inhibitors decrease with aging? No. In fact, if there's, especially with heart failure, there's actually benefit across all ages. That's from the trial populations of DAPA heart failure. Most patients were over 65, and there were a considerable number of patients above 75. There's no decrease in efficacy. However, as the eGFR decreases, there is some decrease in, they're just not as effective in lower GFRs. So there's a GFR cutoff, which I'll show you in this section of the talk. So you don't use them in people with GFRs under 30, although this GFR cutoff will be lowered eventually in the next year or so, I believe. So no, you can use them. So yeah, they're pretty beneficial.
Okay, and does the
that's what I'll cover in this part of the talk, which is appropriate patient identification and how to pick and what you counsel on. So these are some of the common questions I get. I don't know which one to pick. I don't know what to do with other medications when I start this new drug on my patients. And then the very common one is, yeah, this is all great, but none of my patients can afford any of this. Why are you telling me to use these? So we're going to cover all that. So this is I don't expect you to read this, but this is actually the medication selection sequence algorithm from the ADA. And it has, with time, gotten more and more complex. But I'll break it down for you. And I'm going to primarily show you where the changes have happened over the last 2 to 3 years with all this new data. So metformin is, of course, the first line of therapy along with lifestyle modification. But if there's an indicator of high risk cardiorenal disease, you want to pick based on that. So you can even consider it independent of baseline A1C. Based on our heart failure, DAPA heart failure, and Emperor reduced trials, you can use these drugs even with in people who don't have diabetes. So the bottom line is, in 2021, management of diabetes is not just based on safety or glucose lowering efficacy, but it's actually based on cardiorenal status. And if you go down the yes or no, so the algorithm says, so look to see if a person has ASCVD, CKD, or heart failure, and you go down the yes or no pathway. If it's yes, I'm going to show you in the next slide what you pick. And if it's no, which I'm not going to talk about today, but it's primarily still SGLT2 and GLP-1 analogs because of their weight loss benefit. So these newer drugs are are recommended to be incorporated as early based on patient characteristics, especially cardiorenal status. So high risk ASCVD, how do I pick? So if you have someone with heart failure, so that's shown in the center, meaning a left ventricular heart failure with reduced ejection fraction and their LV is less than 45, you pick an SGLT2 inhibitor with heart failure benefit. So that's all four drugs have shown benefit in CVOTs. If you've got somebody with ASCVD, your choice of drug, first choice of drug would be a GLP-1 analog, and preference would be semaglutide, liraglutide here, as I've shown you. If you've got somebody with CKD predominance, you try to pick a drug which has evidence of decreasing CKD progression, and that's the studies I showed you, Credence and DAPA-CKD, which is canagliflozin and dapagliflozin. Okay, that being said, the caveat is this is not how it works in real world. My recommendation is so you can use any of these drugs. For heart failure and CKD, there's no heterogeneity. It's a class effect. So you can pick any drug, pick your drug of choice. It depends on coverage. And I'll show you down in a few slides. Empagliflozin has very wide coverage. I would pick one flozin, try for that and see what the insurance comes back with and go with that. So the next question is, how do you incorporate these new drugs? What adjustments do you have to make? So these drugs can be added to all varieties of glycemic lowering therapies. It could be added to insulin. It could be added to sulfonylureas. There's just a few things you have to keep in mind. With SGLT2 inhibitors, if your patient's on a sulfonylurea or insulin, there's a slightly higher risk of hypoglycemia that will require dose adjustment. If they're on diuretics, you want to assess their volume and look at volume depletion, what their GFR is, because the first few weeks there will be, so these drugs the SGLT2 inhibitors cause polyuria, there's dehydration, so you have to encourage them to drink a lot of water. So it's not necessarily the best drug for somebody who doesn't have an intact thirst mechanism or not drinking enough water. There will be a drop in GFR, it's reversible, and up to 30% drop is fine. For the GLP-1 receptor analogs, most of the time you really don't need to adjust medication. If they're on insulin, you can monitor, you can give patients some adjustment options. Side effects you should be aware of. Important to know, SGLT2 inhibitors cause loss of glucose in the urine, so very high risk of urinary and genital mycotic infections. Because of that, it's very important to maintain good perineal hygiene. Rare necrotizing fasciitis of the perineum, otherwise called Fournier's gangrene, can happen, and that's primarily because there's glucose in the urine. If you have poor general hygiene, it's not the best person to start these medications on. There's some signals of increased fracture risk. So in your older patients who are at risk for falls, you may not want to use these drugs. And there is something called euglycemic diabetic ketoacidosis in an acute illness setting that happens where because of use of these drugs, the patient's not able to mount a hyperglycemic response. Ketoacidosis can happen even with blood sugars of 200, 250, whereas typically would be 400, 500, 600. This is more in people who have undiagnosed type 1 or autoimmunity, but it's something to keep in mind. GLP-1 receptor analogs, the main side effects are GI intolerance, and it's dose dependent. There's really no risk of pancreatitis or pancreatic cancer that has come out of any of the large trials for the GLP-1 analogs. So if you have somebody who had a remote history of gallstone pancreatitis, it's fine to use these agents. And there's no pancreatic cancer. So I just want to highlight some challenges in patients with who are older. As I mentioned in a couple of slides ago, the infection risk is high. UTI with sepsis can happen. I've had several patients who've gotten into trouble, but the key is communication and education. So I had a woman who's in her 70s who was on this drug, and she, because of education, she knew what to do when she wasn't feeling well. And it turned out she did have a UTI with sepsis, and she was on empagliflozin. If it's an individual who has severe urinary incontinence, this is not a drug you want to use. Hypoglycemia risk, we talked about euglycemic decay. So educate them about withholding if there's some kind of acute illness or they're not able to eat, and you want to stop 3 days prior to elective procedures. And these are not drugs you want to give in the hospital. With GLP-1 analogs, it's not as bad. However, you don't want to use them in people who don't eat as much or have a suppressed appetite. There's more advantages. It's less injections. You can use them before insulin initiation. You don't have to go to insulin directly. However, if we're getting insulin injections and there's a lot of waste with the, not that that's an issue, but dexterity with injections is primarily the issues that you might encounter with GLP-1 analogs. Coverage, actually, with SGLT2 inhibitors, this was a study of Medicare Part D plans that was published last year. And the authors found empagliflozin was widely covered, and that's been my experience too. With the GLP-1 receptor analogs, it's a little bit more difficult. They tend to be more expensive, but I've had success with use of liraglutide. For Medicaid plans, they're widely covered. Both drugs, so empagliflozin and liraglutide are have pretty wide coverage. Nevertheless, it is important to note that many are not able to afford due to high copays, high deductibles, and donut hole. So using these new drugs is appropriate in our older individuals. You want to decide based on cardiorenal status. The GFR cutoff is about 30 for most of the flozins, and this may drop to even 25. That there may be relabeling, but for now 30 is the GFR cutoff. There's no GFR cutoff for the GLP-1 receptor analogs. Use appropriate agent for well-functioning individuals with low comorbidity. All these drugs can be used, and you want to be careful in people with urinary issues, falls, and frailty, especially with the SGLT2 inhibitors. So in the last few minutes, I'm going to briefly touch upon technology in older adults.
And then just a couple of questions, if I may. Next part. So one of them was, does a single episode of UTI indicate you should stop those medications?
Great question. No. So a single episode. So usually what I tell my patients and what I do in my practice is there's no guidelines on all this. So in my practice, I will treat one UTI. If it happens again, I'll treat a second one. But 3, I usually take them off. I have one colleague who has a patient who's had chronic UTIs, but the SGLT2 inhibitor is so beneficial in their case that they have left the patient on, but I don't believe in chronic yeast infection therapy. So I think I give it two times and then done. But if it's an older individual who had UTI with sepsis and that landed them in the hospital, I just take them off.
And does it matter what's the cause of the urinary incontinence? So overflow versus overactive bladder or urge, or is it just the leaking urine part?
It's just the leaking urine. It doesn't matter.
Okay. And how about if they have a chronic indwelling Foley?
Oh, I wouldn't use it no. I don't, I just would not in an older individual. And with a Foley, probably not.
Okay. Is it also because of the increased risk of UTIs?
It is, primarily UTI risk. It's a real risk. In real world studies, it's pretty high. In the research, in the randomized trials, they report that it's not as high, but in real world studies, it's pretty high. And I think I've had to take several of my older women off because they've had pretty significant problems. So it's not a minuscule risk at all.
Thank you.
Okay, so so using A1C as our metric for diabetes management in older adults has problems, limitations, because even with aging, you can get a mild increase in A1C elevation. And a lot of our older folks can have false increases or decreases. It's really also, as I've shown here, A1C doesn't actually show you the ups and downs, the glycemic variability. It really doesn't pick up hypoglycemia, which is a big risk. So that's where we like to use alternative options like fingerstick glucoses, but continuous glucose monitoring is actually another option that's recently available. There's all kinds of technology available now for diabetes. Blood glucose monitors, you know about, they've been around for a while, but that involves poking fingers, it can hurt, has poor uptake in most individuals. And so real-time glucose monitoring systems where there's a sensor, a little filament that goes in your skin that I'll show you in the next slide, can be used to monitor glucoses constantly without actually having to poke their fingers. And there's also insulin administration systems, such as smart insulin pens, where there's a Bluetooth mechanism. So this pink pen here is an insulin pen, which talks to via Bluetooth to an app on the phone. In highly functional older individuals, these are all options. And there are people with type 1 diabetes who have, with aging, are still on insulin pumps and continue to use them quite effectively. But the technology I want to highlight is continuous glucose monitoring. So CGM systems measure interstitial blood glucose. They don't measure capillary blood glucose like your finger stick. It's interstitial blood glucose, meaning fluid surrounding your fat cells in the subcutaneous tissue. It allows for real-time assessment of glucose levels and trends. So the patient can put it in at home. So this is the sensor that sits on top of the skin. This little filament goes underneath. That's what's measuring the glucose. The chemistry here is similar to your the finger stick, the test strip, and it's transmitted either via to a reader or receiver that the patient has, or it can be sent to the cloud and to an app on their phone. So the data can be real time, meaning you can see the numbers right in front of you, or you can scan the sensor depending on the kind of technology that the individual use. And you can actually get glucose curves from the data that these sensors generate. And this is a called an ambulatory glucose profile. Looks like an EKG for blood glucoses. So that's literally what it is. So it's continuous monitoring of blood glucoses that are checked every 5 to 15 minutes and transmitted and calculated, and you get a curve like this. And so this, for example, goes from midnight to midnight, and you can see patterns and make adjustments appropriately. And this avoids the need for frequent blood glucose checks. Can't completely eliminate finger sticks, but can give you patterns for adjustment of therapy. So you do need to know how to get them. And I won't go into this. I'll let you look at this because we're almost coming up to the 9 o'clock hour. But I will say I am giving a lecture today to primary care on CGM use. It's for a pilot, and I think it's available system-wide and will be recorded. I'll share details in a slide at the end. But this is technology that is available to our Medicare age patients. You just need to know how to pick the right patient and how to document, because it's available for people who take insulin and take multiple injections of insulin and can benefit in many ways. So going back to our patients, our 73-year-old with diabetes, CKD, and Alzheimer's, who's on metformin and multiple injections a day. She has CKD. Would this woman be, her A1C ranges between 7.9 and 8.2%. With her CKD, she might be a person who you might consider adding an SGLT2 inhibitor, but that's not what I did. Instead, she wanted to monitor more closely, and she opted for the intermittent scanned continuous glucose monitor. And the interesting thing is her husband helps scan. He scans it and he gives her that's how he cues her to say, hey, this is what's happening. It's time for lunch. You need to take insulin. And so this has helped her stay in the mid-7s recently. And so older adults can also, even with, if you have a supportive home environment and resources, it is available. She meets the criteria for use of these sensors, Medicare criteria, so she was able to get this. I opted to not start her on an SGLT2 inhibitor in her case, and she's doing fine. Whereas our 83-year-old highly functional retired geologist with coronary artery disease, microalbuminuria, EGFR of 55, he would be a great candidate for starting empagliflozin or an SGLT2 inhibitor. For him, empagliflozin was covered. That's what we started, and he's doing well on this drug. Diabetes management in older adults is many layered, nuanced, has many unique challenges. Complexity of regimen should actually be match the patient characteristics. You can use newer therapies in our older adults with appropriate patient selection. Diabetes technology is also available, especially for Medicare individuals who take multiple injections a day. And you want to also appropriately simplify regimens when appropriate. And with that, I will stop and take any more questions. My system-wide CGM presentation for primary care details are here. It's on Zoom, but it'll be recorded. And if anybody's interested, please reach out and I will, I don't know where it'll be put because it's through primary care, but it's a good learning opportunity if you're interested. And with that, I will stop and take questions. If there's any more questions. I wasn't monitoring the chat. I apologize because I minimized everything.
No, it's okay. I was monitoring. Those questions that I asked were all from other people.
Okay. Can I stop the share now? Or I was asked to put up this QR code.
Okay. I think everyone got the QR code. I think Diane also put the link for the survey in the chat.
Hey, thank you for the talk. This is Angela from the Memory Brain Clinic.
Yes.
You mentioned our clinic for your first patient. Yeah, this was really helpful. I mean, obviously we see a lot of patients with diabetes and then they start having memory complaints, all the way from early mild MCI all the way up to dementia. What do you counsel about diet? And does it kind of depend on what stage they're in of diabetes? Just very briefly, kind of how I approach it is if they're in the early stages of Alzheimer's, I'll, move mountain and earth to try to eat healthy. Mm-hmm. If they're in the later stages, I say eat ice cream and give them more insulin, like just let them eat what they want. But I'm definitely interested in your opinion on that.
Actually, I completely 100% agree with you. So my first patient chair, she goes to, every day she eats a coffee cake from Starbucks. Am I going to fight that? No. So that's why she takes 5 to 8 units of insulin for that coffee cake that's often extra. So it really, again, it's individualized. Do I recommend anything specific? If it's early, carbohydrate restriction, as in limiting carbohydrates, refined carbohydrates, just general principles, nothing specific. If I've got somebody who's, undergoing chemotherapy for cancer, they can eat ice cream, they can eat their donut, and we'll just fix it with insulin if that's what they're on. Yeah, it's really, I don't have any other specific, but I think what you described is perfect.
And I guess just to kind of add on to that, it's interesting, a lot of the newer agents, mm-hmm. Some of the side effects kind of mimic symptoms of dementia, weight loss, appetite changes.
Yes.
So I think it's just something to be really mindful about. Yes. If someone does have mild to moderate AD, like they're not eating or forgetting to, is it their drug, or is it their
so that's a good point.
Med, like maybe we should take them off their Aricept.
So as opposed to, I would say, if it's somebody who's not eating and is losing weight, those would not be the patients who should be on a GLP-1 analog. If it's a frail individual who's already lost a lot of muscle mass and they're really skinny, and I mean, it's I just don't want them losing any further weight. So I actually will document saying, like, this is why I didn't pick a GLP-1, because, bane of our EMR, nobody reads the previous notes anymore. So I'm careful about what I pick for what patient. So, when in doubt, insulin is easy. Yes, there's hypoglycemia, but, you can target them for A1Cs that are slightly higher, and you can use CGM if possible, if needed. There are families who will spend for the intermittent scan CGM that's called the Freestyle Libre. It costs about $50 a sensor. If you buy it for cash in one of the big box pharmacies. Yeah, and you can put it on, it's the last 14 days, you can put it on 2 weeks a month. There's different ways you can monitor and use therapies, but it's all about characteristics of the patient, as you mentioned, rightfully. So.
And someone, Heidi was asking what time is that conference today? And if we can have the chat.
Yeah, so I have to look for I don't have my email up. I can email it to your administrative person. I have it in my email calendar. I turned off everything, I don't have anything up on my screen. But it's from 12:15 to 1. Okay. So the UW neighborhood clinics is piloting CGM use in primary care. I'm doing a training lecture on use of CGM for that pilot, but it's open system wide, I think. So.
Thank you.
Okay, all right. Well, thank you, everyone. I hope that was somewhat helpful.
It was great, thank you. All
right.
Good to see things open up, and I know you mentioned that the slides will be in MedHub.
Yes, I'll put them up right after. I get off. Yeah.
And if someone doesn't have MedHub, is it okay if we download it and send it, or just a copy?
That's fine. Okay. All right.
Thank you very much for being here.
Yes, thank you as well. Okay. Bye-bye.
All right. Thanks, everyone. Bye.